everyone, and welcome to another episode of MedSynapse podcast series. I'm your host, Tetvisha, and today we are diving into a topic that touches the lives of countless families worldwide, which is pediatric cardiac surgery for congenital heart disease. These tiny hearts face big challenges, but thanks to the marvels of the modern medicine, the outcomes have improved dramatically. And to help us understand this intricate subject, we have an exceptional guest with us today, Dr. Tanushree Kar, a highly skilled cardiothoracic and vascular surgeon. Doctor has dedicated her career to addressing the most complex heart conditions, including congenital heart defects in children. Her expertise and compassion have earned her immense respect in the medical community. So, Doctor, thank you so much for joining us today, and it is a pleasure to have you.
Thank you. Thanks for the invitation. It's my pleasure to join you for this interview. Yes.
Likewise, Doctor, I'm very so excited to hear your insights on this topic. So, Doctor, before we dive into today's main topic, could you just share your professional journey with us and what actually inspired you to specialize in cardiothoracic and vascular surgery?
Yeah, starting as a medical student, I was always interested in surgery. It always thrilled me. It was very exciting to, do something with your hands. It creates a result. You can operate on something by yourself, create something by yourself. So when I studied and read about cardiothoracic surgery, so it was one of the most challenging surgeries. You get to stop the heart, operate upon it, and bring the person back to life. So it's a different kind of thrilling, and the joy you see when patients recover is immense. They dramatically improve, you get gratifying results. Definitely, it's very critical, and in that part, you have to also train for that for a long time. You have to understand, but it is quite thrilling. So that is what inspired me, the challenge and the outcomes as well. So after I did my MS surgery, I did my MCH from AIMS New Delhi, which is one of the most premier institute for cardiothoracic surgery. So that has been my journey. Yeah.
It's actually very clear that your passionate and dedication have driven your work so well. So thank you for sharing that. Now let's just dive into our main topic today. Pediatric cardiac surgery for congenital heart disease, especially, is such a vital area of healthcare. So, over the years, how pediatric cardiac surgery has evolved significantly. So, from your perspective, how has this transformed, particularly in managing congenital heart diseases?
Yeah, see, earlier cardiac surgery is not a very old science. As you'll see the literature, surgery itself general surgery dates back to thousands of years to Shushruta. But cardiac surgery, it started in 1950s with the advent of the heart lung machine. Before that, it was forbidden to touch the heart. So after the heart lung machine was introduced, cardiac surgery, adult pediatric went side by side parallelly. They evolved over time. So early era focused 70s and 80s focused mainly on the repair of the simple lesions, open heart procedures, and development of the basic cardiac surgery in congenital cases. Then we came to the 80s and 90s, our technology developed, our diagnosis developed. So development, evolution went in parts with the diagnostic part, with the therapeutic part, as well as the knowledge among masses and their accessibility and affordability, particularly in India. So the in the diagnostic part, we have more advanced echos, CT, MRI, all that developed. So we started getting better diagnosis and better referral of patients, with more accurate diagnosis. And once the diagnosis came into place, then it also comes as a matter of reaching to the masses, to the rural areas, peripheral areas. More and more setups were developed, more and more centers came up. And then coming main to the surgical part, in the 80s and 90s, we have more developed perfusion system, ICU management, and obviously with better diagnosis, we went ahead to operate more complex congenital lesions like switch. So it was not like in India, it was developed much later. Like in US, if it went ahead in 1975, the first switch took place by Dr. Jatin. So in India also, it followed. It did not follow take much time. It followed soon after. Many of the Indian surgeons went to and fro abroad to New Zealand, Australia, and US for train under the Masters of Cardiac Thoracic Surgery, and they brought back. So in India, the complex congenital lesion surgery also followed parallelly, and various centers developed, which were like the Satyasai, which are dedicated particularly for pediatric cardiac cases and pediatric cardiac surgery. AIMS caters to a large population of pediatric cases. There are dedicated pediatric cardiac surgeons there. So after all this, we were able to take the complex congenital lesions. We have come to an era where now simple congenital lesions are treated even by minimally invasive approach. Let's say like ASD and VSD, many surgeons are adapting to the minimally invasive approach. So apart from the surgical part, we have more advancement in the prosthesis availability. We can get exact imaging of the patient. There's 3D printing has also come into place, which gives us the replica of the lesion. It helps people to understand the exact anatomical defect. It helps surgeons to practice. So it is on the way yet. It is not there everywhere, but it is the future there. And there's tissue regenerative therapy which is going to be there in future, but
Mm.
yeah, it is rapidly progressive and going forward. Yeah.
Yes, I think it is so incredible to hear how actually innovation and dedication in this field have actually, paved the way for better outcomes.
Yeah, it is the technology is as much involved, and you have to go along with everything. You cannot just diagnose, you cannot just have
Hmm.
the surgical part. You have to have the post-op care. The patient should understand, they should have the education, the family should know. So all these go hand in hand in the evolution of pediatric cardiac surgery.
Yes, I think that is very necessary also. And I'm sure, like, as you mentioned also, it's a constant learning process for
Yeah,
everyone involved in this.
exactly.
Uh, so, doctor, now when it comes to planning surgeries for more complex congenital heart diseases, it must be a delicate balancing act. So, what are the key factors you consider to optimize outcomes in these cases?
See, there are several factors. Like we start with the patient factors, then surgeon and their team factors, and we have to consider the patient's family factors and environmental psychosocial factors also. So when it comes to patient factor, I mean the disease and diagnosis. So first, it has to be definitely there are several congenital lesions which are still very severe or non-repairable to biventricular repair who go on single ventricular pathway. So there first is the accurate diagnosis. Definitely, you have to have proper diagnosis. Any misdiagnosis will not lead to a good outcome. So whether you can go ahead, whether you need a cath study or an MRI, whatever, you have to get the exact lesion in congenital heart disease. Then with patient, with respect to patient, if it is a neonate, if it is a 1 day child or a 1 month child or a 1 year child or an older child, how is the patient presenting, the weight of the patient, weight with respect weight and height, growth with respect to
Hmm.
age, how is the development, whether patient has developed any heart failure or having recurrent infections. In congenital cardiac cases, patient many times present with failure conditions, then they present with recurrent LRTI, poor growth, poor nutritional status, because heart conditions do not allow them to grow properly. But in some certain simple lesions, they grow well with time, but definitely they need a repair there. So patient condition will also determine how the outcome will be. The sicker the patient, definitely we have to consider a higher risk of poor outcomes. The better the patient we have. If the patient is sicker, then we may take some time to optimize the patient to a more operable condition for a favorable outcome. Then comes the surgeon and team factors. Like the surgeon should be well experienced as well as should understand the anatomy and the outcome and planning of the team, including perfusionist, anesthetist who know how to deal with smaller children. There has to be, setups. Then for pediatric cases, there need to be dedicated staff who will take post-operative care. In pediatric cardiac surgery, it's not just the operative part. You have to optimize before surgery, and post-operatively, the children may go from good to bad in a very short while. So the post-operative care is very critical, and no two children are exactly same. You cannot give blanket treatment, and every some will have high pH, some will have low tolerance, some will have high saturation requirements, some will tolerate desaturation better. So it is very tailored ICU approach. And then definitely financial and patient factors are there. How much the parents understand the outcome. Like every repair is not a complete repair. It could be a staged repair. It could be a partial repair. And they may lead a near normal life, but they may have certain limitations as well. So the patient should agree to, relatives should understand, family, that the patient will need some care and regular follow-ups and checkups and proper medication. And when if a staged procedure is planned, then they should visit in the right time and should not delay further. That all these factors definitely define the outcome for the patient.
These are some key factors also to consider. And one more question, just following that, which factor in your experience is very crucial?
Most crucial is definitely the patient diagnosis and presentation. Most
That
crucial.
is something
You
that
know,
you need to really
yeah. One
diagnose
has
well.
to diagnosis, and based on diagnosis, you can say if the patient is in heart failure and very sick. So definitely we are going to have a relatively may have a poorer prognosis. The patients who are better and proper, like let's say ASD or VSD child is there with no
Mhm.
PAH, they will do better after surgery. But if a child with obstructed TAPVC is there who has severe PAH, then the outcome may not be so good. It depends totally on the surgery, on several factors during surgery, post-op care. So definitely the diagnosis.
Rightly mentioned. So, like as mentioned by you, doctor, post-operative complications can be a significant concern. So, especially in pediatric cases, considering the age. So, extracorporeal membrane oxygenation, also known as ECMO, has been a game changer in many ways. So, how has its use evolved in managing these challenges?
Definitely. As we discussed in evolution, we could take up more challenging cases.
Hmm.
So earlier it was only cardiopulmonary bypass which came into being. Then there was invention of extracorporeal membrane oxygenation. So what it helps is that what extracorporeal membrane oxygenation does is that it unloads the heart. It's a miniature CPB, you can say cardiopulmonary bypass. So it is a very short circuit. It uses a centrifugal pump, and you can just run it on a low heparin. What it does, it unloads the heart, okay, and it provides oxygenation, perfusion to the entire body. So it there are two types of ECMO, you must know, like where veno arterial as well as veno venous. In pediatric cardiac cases, we mostly use veno arterial with central cannulation. So, how it helps that when a patient, let's say TGA patient is there with intract ventricular septum or regressed LV, who are not expected to do very good after surgery, who might have an acute heart failure. So, in those patients, electively ECMO, if instituted, it helps in unloading the heart post-operatively. That reduces the myocardial oxygen consumption and demand, that gives the heart time to recover and rest. And by, let's say, 2 to 3 days, often the heart recovers well once unloaded. And in the meantime, the circulation and respiration, all the oxygenation is maintained by ECMO machine. There you can very much control how much oxygen to give, how much CO2 to be washed out. And child can be, if the lungs are also congested, like in TAPVC cases, sometimes in obstructed TAPVC who have severe PAH, so the lungs can also get rest. So it helps in such regressed LVs, or with very patients who have been operated with very low ejection fraction or in failure, or if during surgery and due to some unexpected myocardial injury, or let's say edema post perfusion, when we are coming off bypass, if we are not able to wean off bypass, we can rest the child or the heart for 1 to 2 days on ECMO and then gradually wean off. Apart from these, like I told you, in obstructed TAPVC, there are certain cases of PH crisis. So while it gives rest to not only heart but also lungs, okay, and it unloads the heart. So when PH crisis happens, there is strain over RV, and the cardiac output suddenly falls. So after operating, if there is risk of PH crisis, you can keep the patient on ECMO, the heart rest, the pH, we give medication, pH settles in a day or two, and then we gradually load the heart so that we prevent any pH crisis. So that is how ECMO has helped in a lot of cases. It is almost as good as, any mechanical circulatory. It is a mechanical circulatory support. It acts as a temporary heart for time being, and even if it can act as a dialysis machine also. It helps in ultrafiltration also. So it is a very very helpful, instrument for cardiac surgery.
It's so remarkable to see how ECMO actually provides critical lifeline also during recovery
Definitely.
to children. So now, Dr. Measuring the success of pediatric cardiac surgeries is obviously very essential. So not just in the short term, but also for the long term quality of life. So what benchmarks do you consider most important in assessing these outcomes?
See, if we talk of immediate, we can, divide it on immediate outcomes or intermediate or long term. So, immediate benchmarks would be like our primary endpoints are mortality. Definitely, how is the survival of the patient, and how much the extent of, repair, the adequacy of repair that has been done. Then other benchmarks in immediate term we can say are how much is the stay in ICU, how much is stay during the hospital, whether the discharge is early. Then in any cardiac surgery, there is risk of stroke, CVS also, very miniature, but there is. So you have to assess on those parameters if the patient has suffered any kind of CVA, if there's any arrhythmia, which are more common in congenital, cardiac cases. Or so these are the parameters that determine the immediate outcomes that tell you whether the outcome is good or bad. Then in the intermediate, when you immediately follow up, then we can see how the child is, there's gain in weight, feeding, activity. These parameters are monitored to assess, the success of the outcome. In long term, basically you see how near normal life of the patient is. A good repair, a good outcome can provide almost a near normal life to a patient. They go ahead to attain education, to have a normal social life, have a normal family life. Many of the children have treated for complex congenital heart disease 30, 40 years back now have their own children, have gone through several phases of life successfully. So that is the long-term benchmark definitely for biventricular repair. But in single ventricular repair, like I was saying, definitely life is sustained for a shorter time. It is not like a fully normal life. So yeah, to the expected life expectancy as per their lesion and as per their repair, that has to be the long-term benchmark.
Yes,
Apart from
actually.
yeah,
Hmm.
uh, near normal life. Right.
Yeah. So, from your extensive experience, doctor, could you share one memorable case with us?
Yeah, congenital cases like, let's say, a child, I remember, with obstructed, like I said, obstructed TAPVC. And once they come, their urine output was falling, child was intubated, and then the child was we could not, and there's always high pH in such cases. Option, most medications even given, they will not, relieve the pH because it is obstructive kind, you have to take patient for surgery. So then patient was taken for emergency surgery, and it's at that time patient was very sick, but once operated, the obstruction was relieved. So the TAPVC repaired was complete, and the child came home. When came to us, acute failure, and had a very low birth weight and very low weight, like 2.5 kgs. And once operated and went home and successfully, and then came back, gained weight. So it was very good to see, and all the defect was repaired. So it is so fulfilling to see, a child having such low weight, not going almost in failure, and a simple repair. I would not say a simple repair, it's definitely complicated, but a repair, a successful repair rather, gives such a good outcome and a new lease of life to a patient. So that
Yes, these outcomes would actually be very relief for doctors as well, especially considering the age of the children.
definitely.
Now, finally, let's address some misconceptions as well. So, what is one common myth or misunderstanding about the pediatric cardiac surgery that you often encounter, and how do you address
Rather than one, I would say you two.
it? Sure.
These are two extreme spectrums.
Mm-hmm.
Like certain simple congenital lesions, even though we have now more diagnostic reaching to the periphery, more access to healthcare, but certain lesions, let's say ASD, simple defects like ASD, VSD, they are being told, even by some medical practitioners also, uh, patients are being told, okay, it is insignificant. So what happens in childhood, it may be insignificant, like certain, and they are being told that it is insignificant or it may close on its own. So it is true to certain extent for some kinds of VSD, but that does not happen after 6 months or 1 year. So after that, even if it is a simple VSD or AS, in early stages they face no problem, but later they develop such high pH and they become inoperable. So, and they come to us in inoperable stage. So that is one spectrum of misconception, that they are being told that it's nothing, it will close on its own because they are not very symptomatic. At least they need a follow up, and definitely larger defects have to be closed. And but the other spectrum is, especially with complex congenital or cyanotic heart diseases, comes as they are being told after birth, some doctor or local practitioner or somebody has seen the child is cyanotic, and they are being told that it is inoperable. So a proper referral is not done. They are being told that the child is never going to be okay. Even now we have, we are able to operate most of the congenital cardiac diseases. So they are not referred, and sometimes they present very late, or don't present at all, or accidentally present. So those are the two spectrums.
Mm.
And in India, one thing definitely remains is our financial constraints. So they often think sometimes that it is going to cost a huge sum every
Mm.
surgery. So in India, it is, and there are several institutes that are specifically dedicated for cardiac surgery of congenital cases, and there are now healthcare schemes in place that one can easily use. So proper referral, diagnosis and proper referral remains a major problem, and we have to make patient and families how we tell them that okay, it is there, whether symptomatic or asymptomatic, it is going to, we have to explain the prognosis, how the life is going to be with surgery and without surgery, the risks related to surgery. And then we have to, make the parents also comfortable, and that, you should go ahead with surgery to have your children have a normal life.
Yes, I think it becomes very difficult for parents also to get the right kind of guidance through the patients and like through the doctors. And as you mentioned in the beginning, also the most concerning factor obviously is diagnosis. Now I know why you mentioned that. So yes, it also becomes very crucial. So thank you so much, doctor, for this conversation, and this has truly been enlightening for me as well. I'm sure it would be for our audience as well. So thank you for so much for sharing your expertise and shedding light on this intricate topic of pediatric cardiac surgery.
Thank you so much. Thank
Thank
you.
you.
Yeah.
And to our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, wishing you all a good health and knowledge to inspire care. Take care.